Hi, everyone, and welcome to the Global P.A.D. Impact Awards. Today, we are announcing the biggest breakthrough in walking as therapy research. For patients with peripheral artery disease, a condition causing poor circulation in the legs due to artery blockages, walking is truly the best medicine. This therapy helps patients build a vital collateral network of vessels that bypass those blockages. There are little leg savers or are little lifesavers that they go around your artery blockages in the coronary region. However, for the millions who are living with both PAD, that peripheral artery disease, as well as diabetes, a major risk factor for peripheral artery disease, maintaining an effective walking regimen can be particularly challenging due to the debilitating cramping and pain in their legs and in their feet. And this is why today we have the honor of recognizing an extraordinary breakthrough in PAD research. The groundbreaking STRIDE trial, led by Dr. Marc Bonaca and his entire team, has demonstrated that semaglutides, typically used to treat diabetes, significantly improve walking distance in PAD patients. This improvement is crucial, allowing patients to better develop those life saving and limb saving collateral vessels around those blockages. It is my privilege to present the Walking as Therapy Breakthrough Research of the Year Award to Dr. Marc Bonaca and his exceptional team for this transformative work. The STRIDE trial has fundamentally changed our approach to PAD treatment, or at least we hope it is, demonstrating significant improvements in walking capacity, symptoms, and overall quality of life for these patients facing this dual diagnosis. Dr. Banaka, on behalf of the Global PAD Association, we are honored to present this award in recognition of your team's pioneering research. And I hope in our conversation today we can explore the remarkable impact of this study, how it has been received by the medical community, and of course, the exciting next steps in the work of this research team led by you. But Dr. Banaka, congratulations to your team, and perhaps you can begin by sharing what inspired this revolutionary study that offers what we believe is a powerful new approach to PAD treatment.
Well, thank you so much. I mean, this is an incredible honor. We are a community, patients, scientists, clinicians. We're all trying to achieve the same thing, which is, a world without atherosclerotic vascular disease and a world without peripheral artery disease, or at least a world where people can
Mhm.
live a high quality of life, even with peripheral artery disease. And it's a very challenging condition. I know many of the listeners are afflicted by this. It's debilitating, and I think many times under-recognized by many clinicians of how much people suffer. I had the opportunity in my training to train in vascular medicine and really
Yeah.
get to know a lot of patients who are suffering and understand how profound a limitation it is to not be able to walk across a room or play with your grandkids or get the mail. The fear of having to stop or not knowing where to stop, all of those things. And to me, that was really wake up call and an opportunity where we have so few effective therapies to look for better solutions and better treatments for patients suffering from PAD.
And what I love in terms of this study, just one of the benefits is that I think it's raising even greater awareness for PAD with not only diabetics, but also those who treat them on the front lines, the endocrinologists and the podiatrists, and especially our gatekeepers, the primary care physicians.
I think that's absolutely right. Everyone or many people understand that chest pain's a bad thing, or that, having what a heart attack is. Many people don't know what peripheral artery disease is, or what it means when your legs ache when you walk, or they're tired, that could be a real severe blood vessel problem. And a lot of doctors don't really recognize that either. We don't have uniform recommendations for screening. It really is dependent on a doctor asking, how's your walking feel? How do your legs feel? And really understanding the risk factors and how to detect PAD, and also for patients to understand that they're at risk. And so of manifestations of blood vessel problems like heart attack, stroke, and PAD, it is by far the least well recognized, but there are over 12 maybe close to 14 million Americans that suffer, over 230 million worldwide, the majority or many of them undiagnosed.
Yeah.
And what's so sad about that is that it's the early stages of treatment, like we studied in STRIDE, where we have the most potential to impact the course of the condition.
Right. It's when the doctors, the patient starts complaining, with what they think is neuropathy. And the doctor says, yeah, you just have diabetic neuropathy. But now, in light of this research, these doctors might say, well, wait a minute, your neuropathy might not just be diabetes alone. It might be poor circulation, and we need to send you for an ABI test. And it's great. You know what? You don't get the traditional leg cramps as a lot of what the traditional, the textbook PAD patients that have more of the above knee disease typically have from smoking, et cetera. I mean, they get this below the knee disease. And a lot of that, it's burning in the feet. They describe it as, oh, I think I have neuropathy, I have numbness, things like that. And you guys have the ability to, the doctors do, to say, hey, we need to get this test. And it's so amazing that we have a conservative solution that may stall progression. I mean, that's huge.
Well, and as you said, I think maybe for a lot of clinicians, there was a sense of, well, we don't have a lot of things to treat with. We don't have a lot of good tools. And so I'm not
Yeah.
going to look for it. I don't think that's really a great answer for that. But I think the more, as you said, the more effective therapies we have that not only make people feel better, but function better, survive longer, reduce amputations. I mean, these are really critical things. And if we can identify patients that'll benefit early, we need to do that. But, most people don't come into the office saying, I've got a clogged blood vessel in my leg. They don't even talk about their walking. A lot of people self-limit. They realize that walking's getting harder. They think it's just a part of normal aging, maybe, or explain it away. And then they're not checked, and often don't really present until they've got a big problem.
So the STRIDE trial showed benefits across all BMI levels, suggesting the improvements actually were not driven by, and a lot of these drugs are used a lot for weight loss, right? What specific vascular or anti-inflammatory mechanisms do you believe are really responsible for the semaglutide's benefits in PAD patients, and how this actually might reshape our understanding of these GLP-1 agonists as vascular drugs?
Yeah, thank you for that question. The story goes back to a sub-analysis of a trial with a predecessor drug called liraglutide. And there was an analysis from a trial called LEADER where they showed that these drugs reduced heart attack and stroke. And they looked at diabetic foot ulcers and amputations, and there was a pretty robust 30 to 40% reduction. Now, this was a sub-analysis. So, in medicine, we consider that as brings up the idea, hypothesis, but it's not proof necessarily. You have to do a prospective trial. But that really got us thinking that these drugs aren't just the big arteries that we think about with cholesterol plaque, but a lot of the problem we're dealing with function and with patients with diabetes and PAD is what's called microvascular disease. So the small vessels that supply the muscle, that supply the skin, the same issue that happens in the retina and the kidneys. And so there was this idea that there could be a microvascular benefit, maybe mediated through anti-inflammatory properties. And so, STRIDE was one experiment where we really robustly and rigorously looked at function, symptoms, quality of life, and markers, hemodynamic markers like ankle brachial index, which actually improved. And to my knowledge, is the first drug to show that you can improve that marker. And then there were other trials. There was a trial called SOUL, which looked at a big population of diabetes and showed that this drug over 2 to 3 years reduced the risk of things like being in the hospital with a clogged blood vessel or having critical limb ischemia. And so the whole spectrum shows that this is not a weight loss phenomenon. In fact, weight loss was pretty modest in STRIDE. A lot of patients suffering with peripheral artery disease aren't also suffering with obesity, and it didn't matter in STRIDE what your body weight change was. There was a very minimal correlation. This really appears to be a direct vascular effect, but not just for the large vessels, for the microvasculature, and it's so exciting. because we have not had effective therapies for that in the past.
Well, you're going to love this question. So, given that, and it might be the $1,000 question or $1 million question, given that semaglutide, they improved ankle brachial index and showed vascular benefits, seemingly independent of that weight loss, what are your thoughts then on its potential efficacy in PAD patients without diabetes? I mean, would you anticipate similar benefits, and what regulatory or clinical hurdles do exist for prescribing semaglutides to this population in particular?
Great question. Yeah, and just to your point, STRIDE, we did restrict the population to those with diabetes. But there was an earlier trial, a very big trial, looking at cardiovascular outcomes, so heart attack, stroke, cardiovascular death in patients even without diabetes, called SELECT. So people who had a body mass index above 27, who had PAD or a history of coronary disease or a history of stroke, and it showed a really robust reduction in those outcomes. And so we don't know from STRIDE whether semaglutide would improve function in someone with PAD without diabetes, but we do know in that population, if they have a BMI above 27, based on the SELECT trial, that they would have a reduction in heart attack and stroke. And so you could prescribe it, and should I think, if it's in a applicable patient, consider it, and I would hope it would improve their symptoms. So there are ways to access it even if you don't have diabetes. But I think more importantly, we need a prospective trial to demonstrate that there are functional benefits in patients with PAD without diabetes. And my hope, and I strongly suspect that there will be trials and coming out in the next year or two, or starting at least looking at this question.
Are you going to be leading them?
I may be involved. I may be involved, and I nothing.
Hint, hint.
Yeah, nothing definitive yet, but I suspect that we will have that opportunity to answer that question.
And so, and how long do these trials do? There, it's going to be, it would be a couple years probably, before we
Yes.
would know, or before we would see anything. And you do need to overcome that clinical hurdle before you can go to the regulatory level for the PAD patients in particular, correct?
That's correct. I mean, STRIDE already, there was the European Medicines Agency, the group that advises, they put out a very positive statement about STRIDE for approval. I know that it's likely to be reviewed by the US FDA. They'll have to make their decision, but I will say it was a very rigorously done trial that hopefully would meet, regulatory standards, and future trials would need that as well. But I think that's exciting because it shows we can make a difference.
At least when it comes to patients that have diabetes and are at risk of PAD, or people who are diabetics and do have PAD, I know the STRIDE trial evaluated treatment over 52 weeks. I'm curious your thoughts on I don't know if there's been any discussion on the optimal duration of
Yeah.
semaglutide therapy for these patients. And would you expect continued improvement beyond 1 year, or is there a maintenance phase where patients could potentially reduce dosage? I know that there are a lot of side effects with these particular drugs that are of
Yeah.
concern as well for long-term use.
Yeah, great question. So the semaglutide dose we used was the 1 milligram, was a diabetes dose. And in the SELECT trial, it's actually a higher dose, 2.4. So this was a relatively low dose, and it was for 52 weeks. And many of your listeners probably know this, but when you do a clinical trial, it has to end at some point, right? And so you have to make an assessment of, did we have an effect? Of course, in clinical practice, many of these therapies, like cholesterol lowering therapies and others, we don't just limit to the duration we studied in the trial. We give them to patients long term. And what I can tell you from STRIDE is that the benefit was apparent early. Within 6 months, there was a robust improvement in maximal walking distance, and you could see all favorable trends for all the confirmatory secondaries for quality of life, symptoms, ABI, and then the benefits continued to grow. And I based on that trajectory, would expect that patients would continue to have increased benefit over time. The longer you're on the treatment, the more it's going to help. And in fact, that's the way for a patient with diabetes, or whether it's a patient with ASCVD from the SELECT trial, you would treat long term. And so I think STRIDE tells us it works, and that the
Yeah.
benefit observed at 52 weeks is clinically important. But I think in the real world, we'd expect the benefits to be even greater over time.
And how do the functional improvements seen with the semaglutides compare to supervised exercise therapy programs or the SEP programs, the gold standard walking as medicine for PAD in particular, just in terms of both magnitude of benefit and sustainability. And then this part is a little rhetorical. I mean, not a little rhetorical. Could
Yeah.
semaglutide complement or potentially replace some current PAD invasive interventions?
Yeah. Well, I mean, I will. I'm so happy you raised this. Supervised exercise and exercise therapy is the foundational treatment for PAD. This does not in any way replace that. This would be a complementary therapy.
Adjunctive, yeah.
Exactly. And the downside of exercise is that it's not very durable. If you stop exercising, the benefits go away pretty quickly. The plus side of exercise is good for you, and it's highly effective in improving walking distance. So everyone should not only do supervised exercise as it's prescribed, but continue on an exercise program to maintain the benefits. Now, semaglutide's additive to that, and the benefits are large. This is what we observed was a 40-meter walking improvement relative to a placebo. To put that into context, a lot of studies looking at how patients feel on a 6-minute walk, that's walking down a hallway on a flat surface, show a 20-meter improvement is clinically important. This is double that, and it was on a 12% grade, a pretty steep hill. And so
Yeah.
it was about 2 to 3-fold the amount of work. And so it was much bigger than that. But we also did a separate study of patients. We had a lot of patients engagement in this study where we determined what's called an anchor measure of like what was clinically important. And this was highly statistically significant. And then, of course, we measured pain, we measured quality of life, all those things said this is a big improvement, but it's a complement to exercise. Now, what is exciting is that we actually saw in the trial it delayed time or prevented rescue therapy. So you mentioned revascularization. Revascularization or putting stents in surgery does make people feel better. They're not very durable procedures. There are
Not
a lot of
durable.
complications, right? And so if we can prevent someone from progressing to need that, that's a
Yeah.
big deal. And then there are other drugs like cilostazol, which is in the guidelines, and it does improve walking, but it doesn't have any other additional benefits. And the degree of improvement is no greater than what was seen with semaglutide. And so even preventing the need for extra pills or medications and costs could be of great benefit.
And I could definitely see. I mean, have you talked to the folks about the next that I know we just came out with the 2024 PAD guidelines here in the US, and it'll be a few more years probably till we see another set of guidelines, and by then everything will be old and we'll have to start new, right? That's how it goes. But I could see this being a new addition to the guidelines, whereby before you have any sort of invasive therapy, as long as they don't have the rest pain, right, or they're not in CLI, that this would be a frontline treatment for, especially right now, a diabetic with PAD. And I would imagine that because our biggest issue is that revolving door of treatments, and we're constantly battling with that because there's not enough being done. So if they do end up in CLI, and that's the beginning of a revolving door of more surgeries and more surgeries, more surgeries, right? It just is a never ending vicious cycle that for diabetics in particular with PAD, that it become a guideline that a patient is actually prescribed that along with having a revascularization to ultimately, hopefully, delay or stall the progression so fewer interventions or surgeries are needed down the road.
Yeah, and I won't speak for the guideline writers, but I'll echo exactly what you said. You have a class of drugs now that's been shown to, improve cardiometabolic indices, prevent kidney complications, help
Yeah.
sleep apnea, reduce heart attack, reduce stroke, and now are class 1 in the diabetes guidelines and in the PAD guidelines for treatment of diabetes. Now, in addition to that, you can make people function better, feel better, have fewer or progress us more slowly towards any type of complication. And so I would hope that this would be something that would be supported strongly in future statements. I mean, I think that the data are quite unique for this mechanism, and they're, well, I'll just say I hope action doesn't wait for the guidelines. The guidelines are important, but I think we've got data today, and these therapies are available. And so I appreciate you highlighting all of this, because I think for clinicians, we can do something tomorrow in our clinics.
And it's something for the Global PAD Association that we do not give medical advice. We do not have any clinicians or physicians on staff. I do have a very robust medical advisory board that does guide us. And one of the things that we got approval for was to literally be able to suggest to patients to ask their doctor about this as a potential therapy, and to point out the evidence, and to have a productive discussion as to whether or not it might be right for them, either as a precursor, hopefully hoping to prevent any sort of future procedures, or as adjunctive therapy along with an intervention. It's not up to us. We're not saying it's right, but it's worth the patients creating a groundswell that they should have a productive and satisfying conversation with their doctor about this. Because if it works as well as you say it does, isn't it worth a try? Just as cilostazol is. Cilostazol, the studies show that what it works in 30% of patients. And if it works only in 30%, but it's worth that try, even though the side effects, then why not with these drugs as well? Why couldn't this be a potential option that they should consider?
Yeah, and I love the comment. Really, what we're talking about is advocacy. And there is so little advocacy for PAD, and patients need to advocate for themselves. Family members, if you're listening, what else can be done for my mom or dad or brother or sister? What can be done, and asking around the data for this. And then I think we need advocacy, if it's approved for this indication by the FDA, or the EMA has already made a favorable comment, but then we need access and coverage, right?
Mhm.
So that people can actually get it. Certainly, it's already indicated for diabetes, and so there is coverage in certain ways. But we need to ask, advocate, and really talk about how important it is to treat PAD.
And patients already see the commercials. I mean, if there's a Jardiance commercial, not to name names. Yes, I did name a name, but it literally, they have a commercial on at least four times during, 1 hour show. And all they say is to ask your doctor. So providing the information out there for patients to say, hey, you know what? Ask your doctor, I think is a really big deal. And so it's something that's really important to us. And we love anything that can be out there that can help our patients walk further and faster to develop their own natural bypasses is a really big priority for us. So we really appreciate you guys with all the trouble that you went through to make this research possible. But I'm curious, what really has been the feedback since? Any gaps that anyone has highlighted, any criticism that has come across that you've had to address? There's naysayers with every single study that's out there. You always have different schools of thought. What has been the reaction?
Yeah, great question. I mean, I think overall it's been a very positive reaction. I think that it's been 25 years since we've had an effective therapy shown for function in PAD, right? The last was sort of cilostazol that was approved, around 2000. And so I do feel like a lot of individuals felt this was an unsolvable problem, and so that a positive trial showing an effect for these outcomes in PAD was received very favorably. There is always debate about what's a clinically meaningful difference. I mean, certainly if you can walk a foot further, does that matter? Is it 10 feet, or what is the threshold for clinical meaningfulness? And there's a lot of uh, there are a lot of gaps in knowledge. There is no amount of walking that is universally accepted as clinically important, and nor can you say that for any study, because all the populations are different. And so there's been a lot of education to do around that, because we had a very robust anchor measure and patient input and all these things to show that what we did or what we achieved was clinically important. But that's been one of the discussions that we've had. Some people have asked about whether the results were consistent regardless of the severity of diabetes. So one of the investigators, Netta Razzulli, at the American Diabetes Association meeting in June, presented data showing that the benefits were the same regardless of how your A1C was, how long you've had diabetes, other medications in the background. So that answered some important questions. And then most recently in Madrid at the European Society of Cardiology, Subodh Verma, another investigator, showed data for men and women separately. And it's always or often the case that women are understudied. We know that patients with P.A.D. women may have different symptoms or responses to therapies. And actually, we saw a statistically significant, important improvement in men and women separately. So I think that's important. People were asking. And then in a few weeks in Vienna at the European diabetes meeting, we'll be showing data in terms of people who continue to smoke and whether the effects are consistent there, or whether it's just restricted to non-smokers. And so there's a lot of learnings coming out of STRIDE, which are helping to answer those questions. But the best part about it is people are asking because they're interested and they realize that this is really novel.
It's interesting. We have I'm seeing him nod. We have Douglas Salisbury, who is the chairman of our PAD Warrior Task Force, our patient task force. And he also leads our brand new smoking cessation program that is designed and dedicated towards PAD patients specifically. It's a weekly smoking program. And so I could see him tuning in when you were mentioning about Vienna. Any hint that you can give us about some of that data, or do we just have to wait and see and somehow get wind of what that data shows?
Well, in our primary paper, we did show some key subgroups, and overall, looked like the effect of the drug was consistent whether or not you smoke. And so, but there's a lot more detail we're going to show in Vienna, like the top line, and what I'll say, because I can't share more of the results until the meeting, is that in other studies, it's been consistently shown that people who smoke have worse function than people who don't, even for the same degree of
Yeah.
PAD. But that, if you're able to stop smoking, your function will improve, and that perhaps having additional therapies can support that. There have been data with this class of drugs for people having fewer cravings. We didn't study this explicitly in STRIDE, but in other studies, people having less utilization of alcohol, less smoking, other activities. And so, there may be some additional benefits. Again, we didn't design STRIDE to answer that question, but there are other analyses out there. And so, I think smoking's a hard problem, and it's hard for the clinicians too, because we know things that we do like revascularization, putting stents in, or bypasses, they don't do well in people who continue to smoke. And there's also, I think, challenges with you know, judgment of, well, if you're smoking, then maybe you don't need this, or we shouldn't do this or that. And, smoking is a, highly addictive. It's very hard to quit. And, we have to help each other and help our patients to do the best they can. I'm really grateful to hear that there are programs to support people in stopping smoking. It is so critical. And I think anything we can do in addition to the medical therapies is going to help people get better.
Yeah, and we would love to have you back. I see him nodding that we would love to have you back even on one of our during one of our meetings and talk to people about the mechanism of action by which smoking damages the arteries and also leads to clotting. And we're really big into diving deep into the explanation. So because we find more compliance with quitting smoking through the process by
Yeah.
really not just saying smoking hurts you. They all know that. We don't even start our first meeting in the 12-week series smoking hurts you. No, no, no. We said you already know this smoking hurts you. We get it. So, over the next 12 weeks that we are going to help you with ways in which you can, quit smoking. But let's start with a great way that as you try to quit, you can replace some of the cigarettes with certain foods and things
Yeah.
can help you with, certain drinks and such can help you with cravings. And so we take a very different approach that actually was driven by patients and designed by patients. And so we would love to have you come and bring some of those analysis and have the discussion and maybe answer some patient questions as well on a Monday evening.
Well, I would love to. And I think it's such an important discussion because at the end of the day, these advances in medical therapy are really exciting, but we can't forget about the fundamentals, which is,
Yep.
walking, trying to quit or smoking, abstinence, healthy diet, all those things are going to provide such important benefits. And then the medical therapies are adjuncts to those important lifestyle interventions. So yeah, I'd love to join.
And after our last interview, that where we first talked about the STRIDE trial, we had a couple of patients that had emailed questions in, and they
Yeah.
have wounds. They have diabetic wounds that are also related to poor circulation, both at the arterial level. But we were talking a lot about the micro level as well. So having both issues, and they were wondering if in the study you had patients that had wounds, or if you were planning something to see if there is an impact in speeding up the healing of some of these ulcers that are related to circulation, whether micro or part of the major superhuman highway.
Great question. And as I mentioned, in that older trial leader, there was a signal that treatment with liraglutide, a predecessor to semaglutide, there were fewer ulcerations that formed and fewer people that progressed to an amputation. There was about a 30% reduction there. So in Stride and Soul and Flow, there was a robust data collection of all these adverse limb events, like not just acute limb ischemia and critical limb threatening ischemia, but actually looking at foot infections. And we have data, and I can't reveal too much yet, but we have data coming out in Vienna and then at the American Heart
Mhm.
Association November, which will show across all of these trials, what the effect of these drugs are and the incidence of these foot infections and wounds. This is the microvascular disease that we have not had solution for, and we have not,
Yep.
but besides glycemic control and foot hygiene, and I think that it's an important opportunity. So we're presenting some data. You saw from the SOUL trial, the primary results, there was a reduction of acute limb ischemia and critical limb threatening ischemia hospitalization for those. And then we'll show a broader review of all those foot infections that people asked about.
So we love all the data that is coming out, and obviously these semaglutides are having a huge impact. But as we talked about in our last interview and even pre-interview here, of course the semaglutides are currently expensive, with variable insurance coverage. So how do you view the economic considerations of prescribing this therapy, for diabetes and for diabetics with PAD, or at high risk of PAD, especially given that it might be needed to be taken long term? I mean, are there any economic analysis that are being done or that are needed to support broader access at this point?
Great question. I think there are a lot of conversations around access. There's a lot of work being done to make these therapies available to individuals. One of the things people have turned to is sort of compounding pharmacies and other agents, and I think there's some risk to that. I mean, these are not regulated to my knowledge, and not what we studied. And I think that's also a word of caution for the listeners that when one drug is studied in a trial, you learn what that drug does, the safety and efficacy, but
Yeah.
that doesn't necessarily mean others in the class, or certainly unregulated things, are going to do the same thing. And so, I really view the results of STRIDE as, relative to semaglutide at the dose that we studied. And, how do you get it covered? Well, it's really challenging. I'd say coverage for diabetes, which all of the patients had, has gotten much better. Coverage for weight loss has been harder, but I think how it's prescribed is really important, because
Yep.
there are different names and so on. And so I think working with your physician and the team around sort of how to prescribe it in a way that it's clear what it's for. Clearly insurance status matters, and depending on where you live, what Medicare, Medicaid will cover. And then I think, hopefully generic forms of these drugs will come. There are a lot of new therapies being developed, oral GLP-1s, others. They'll have to do trials like STRIDE if they want to show a benefit, but I'm hopeful that with innovation, with more therapies, with generics coming along, it's going to be increasingly accessible.
So I just have a couple more questions on the study itself, and then I have 6 questions that we ask every single physician as part of the Global PAD Impact Awards. But I'm first curious about any patient that may stand out, any amazing patient story that you would want to share, that the trial's now over, maybe someone's come back to you and said, "Oh my God, this is still working. This is amazing."
Yeah, I mean, it is. It's about the patients. And I before I even answer the question, I just do want to thank all the participants. I mean, it's easy to be an investigator in a trial. It's work, but I mean, people have to volunteer and sign up. And this
Yeah.
was a hard study. There were, treadmill tests and, blood draws and, getting the treatment, not knowing if you're on the real treatment or the control. And so, if there's anyone to thank for this, it's all the participants who volunteered to do the study. There are a couple folks that I know that were in the study that told me they were feeling better. And of course, I was blinded; they were blinded, so there was no way to know for sure. But they're still on therapy, and they are doing great. And Doug, thank you. I see. Where can we sign up? There are and we could circulate. There are studies ongoing, and there will be new
Yeah.
ones starting where you can volunteer if you're willing to. And it's one of the most generous things that people can do is to volunteer to be in a study like this, because you may not benefit, or you may benefit depending on what you're arming, but what you're really doing is providing benefit for the future generations of people will benefit from your generosity. So it's one of the most important things we can all do. But yeah, I do have a couple of patients who told me they were getting better in the study, and they're still on treatment and open label treatment now and doing great.
And I love that Douglas teed this right up and that you do have quite a few studies. We recently launched PADtrials.org to democratize access, to information about all the latest treatments. And we have had extensive experience with folks in the NHS, and they're giving us one study after another to put on this site for patients to participate in. I'd like to offer that same opportunity for you and any studies that you have in the participating organizations that are doing these studies. Send us the list of them. I can give you a form that they can just fill out. And then we will go ahead, and for universities, we are offering it at no cost. If it is a corporate sponsored thing, then we do have a nominal fee just for all of our administrative work that goes into it. And also our Leg Saver hotline is where the patients end up. Everyone who visits the site calls our Leg Saver hotline, and we're able to facilitate a warm introduction with that patient to the facility or to that physician or clinician that is working on that trial, so they can have a more productive conversation together, and that none of these patients fall through the cracks that have come through the site and are interested, so that we can make sure that they learn more. So we can talk about that offline, and I can
That's
send you the
great.
link and just get everybody signed up, or just populating that. And patients absolutely love knowing what research is being done. They do want to participate. So having that information available, like they do for cancer treatments and outcomes for me, that's what we're doing as well for PAD. So excited, especially for anything that involves, walking as medicine and conservative therapy. That's really helpful. But final question on the semaglutides. So pretend you are a patient and you are hearing this, and you want to have a productive conversation with your doctor. Can you pretend you're that patient and lead us in how this conversation should go? How do they approach this with their doctor?
Great question. So I think first, if you don't know whether or not you have peripheral artery disease, you have to ask your physician to check. And if they don't take your shoes and socks off in the office and feel the pulses in your feet, they're not checking. And if they're not asking you how you're walking, they're not checking. That doesn't mean they're a good or bad doctor. There's a lot to worry about, but push them and say how you're doing. Be honest. Don't minimize your symptoms. Don't make excuses. It's not okay if you can't walk. You should be able to walk. And so don't, a lot of people minimize their symptoms, and you have 15 minutes in the office, and some people feel bad about, complaining about things. Don't say, I'm having trouble walking. This is important for my quality of life. I can't do what I need to do. And whether you're exercising or not, we're all human. You do your best. Don't make excuses for that. And that's number one. And number two is really ask them to have a conversation around the benefit risk of the therapy. I think that's true for all medical therapies. Make sure they understand what your comorbidities are. So if you have diabetes, you already have an indication. They're not, and so they, it's not like they will say, well, let's wait for the FDA for PAD, because you already have an indication for diabetes. And so make sure they understand all the reasons why you could receive the drug. But most of all, really partner with your physician so that they understand how this is impacting your quality of life. That's so, so important for them to understand.
Thank you. That was absolutely beautiful. And I love the way you phrase that it's not just about do you have leg cramps? Do you have leg pain? Do you have trouble walking? Do you find that you're not walking as far as you used to and you don't know why? I mean, that is such a better way, of phrasing that with these diabetics, especially the advanced diabetics with pretty high um, A1Cs. Those
Yeah.
are better questions than do you experience leg cramps? Okay, you don't, then you don't have PAD. No, do you have trouble walking? And so thank you so much for that.
And
Okay,
I'll just make a brief comment that many of us in
yes.
medical school were taught to look for calf pain when people walk that goes away with rest. That's called claudication. That's PAD. That's a tiny, tiny fraction of people who have PAD. Most people with PAD have very different, so heavy legs, maybe just aching somewhere else. Those symptoms aren't what we were taught to look for, but those are PAD symptoms. So to say I have trouble walking, I'm worried about blocked arteries in my legs.
That's huge. I'm going to cut that little clip and I'm going to put that out there
Okay.
just as that clip because that was beautifully said. So thank you for that. And now we have our speed round, our quick
Okay.
speed round. So this is what we ask every single doctor. Some of them are deep, some of them are just a little lighthearted and fun. But first, describe a case that you learned a lesson from that other physicians and clinicians can learn from. It could have been a success, it could have been a failure. But this is really geared towards physicians and clinicians. And I think it would be appropriate if maybe there was something a part of the trial just to continue to raise awareness for the STRIDE trial.
I think that one of the lessons, in a case, well, I'll tell you, there was a case of, a woman in her 40s, a nurse without diabetes, actually, who came in with a wound that didn't heal on her foot, and had seen a variety of different doctors, and not one of them had even considered peripheral artery disease. We have in our minds, this is the kind of patient who has it, and this isn't who doesn't, and I think it's underappreciated. So, unfortunately, by the time she got to us, her disease had progressed and she required an amputation. And there was such a missed opportunity there. If people had just said a non-healing wound on somebody's foot, we have to think about vascular disease. No one's immune. And even though, there are higher risks in different groups, we have to check, feel the pulse in the feet, order the ankle brachial index and figure it out because you can prevent amputation.
I think that almost answers my second question, but I have a feeling you might have another story. So in this one, we're kind of looking at the stereotypical um, misdiagnosis that with typical symptoms. So describe a case where a patient should have been diagnosed with PAD sooner, but wasn't, and because of that, presented on deck for complex revascularization or amputation. And I said, this is just to raise awareness of the delays in patients seeking
Yeah.
care, for a variety of reasons.
Yeah, I've seen this sadly so many times. You mentioned neuropathy. That's often a foil where people get, distracted and don't know there's artery disease. The other one's back pain. I've had a number of patients who have suffered from degenerative disease in the spine, back, and they get pain. People hear sciatica pain going down their legs. And all this pain and lack of walking ability gets chalked up to back disease, or no one checks the pulses. And I can remember a recent patient who really progressed to a pretty severe level of limitation, and nobody considered vascular disease. And by the time they presented, they had pretty severe disease below the knee, which didn't really have any good or very good interventional options, and required some amputation and so on. And I think it's a good reminder that there are a lot of things that cause leg pain and difficulty walking. And
Mhm.
unless we have at the top of our mind vascular disease is one of them, we will miss it.
And share the story of a patient who completely impressed you with their effort to improve their PAD prognosis through their own perseverance. It could be one, that was, as part of the study, but it could have been any patient that you have seen where we had a doctor, for example, a vascular surgeon, Dr. Vincent Rowe from UCLA, who said, this patient was on deck for amputation. And I told her, like, you can try things on your own. And she she actually practiced the art of grounding, found every single sandy beach and got a grounding pad and walked on grass. And lo and behold, a year later, she still is walking, no revascularization. And that was her way in which she was able to persevere with PAD and avoid amputation. I mean, is it clinically proven? No. Did it work for her? She's she has her legs.
Well, I think the lesson is key. I actually saw a patient in clinic on Wednesday, same story. You can you can modify this condition. It is not a foregone conclusion. We all have within our power the ability to make things better. And this is a patient who had below the knee disease, not a lot of good options, pretty severe. We were pretty certain she was going to require either amputation or some kind of Hail Mary procedure. And she just toughed it out, exercise. We got her cholesterol extremely low. She actually changed her diet significantly. And then, some people might shy away because the walking and all that can be uncomfortable at first. She actually got a job in a grocery store where she was walking around all the time, stocking shelves, doing things, and
Mhm.
forced herself to be active. And now it's been almost 2 years, and her function is excellent. She doesn't complain of pain. She doesn't have breast pain. We're not even talking about any type of procedure for her limbs, just risk factor modification. And she came in with just this emanating gratitude and gratefulness. And I was like, be grateful for yourself. You did this. You were the one who made your condition better. And I think it was such an empowering story. And she's a remarkable person.
I love that story. It reminds me of our Dr. Kevin Morgan. He's a veterinarian. He's also has a PhD in pathology. And he was told by UNC Rex, and the reason I say is because you know how good they are, right, at the university and how advanced they are in care for PAD. He had blockages literally groin to toe. He had family history, but he was a marathon runner. And he was like, I can't do this. And they're like, well, I mean, we could try to go in and open. It's going to be a revolving door of procedures. And he said, nope, I am going to do this on my own. He developed through his experience all of these different techniques that ended up leading him at 82 years old to compete 2 years in a row now at the World's Triathlon. It's
Wow.
incredible, and now he just released his book, Training for Peripheral Artery Disease for PAD heroes, something from amputees to athletes, and it's on Amazon. And he's just phenomenal. He hosts our weekly, co-hosts with me. We have a weekly Collateral Nation show. I know that's so cheesy, but we have a place every single week where we
Love it.
invite doctors of physiotherapy, and he and I talk to them about walking as medicine, and we answer just weekly patient questions about walking and their exercise programs. He's amazing, but you could talk to him and there might be some interesting things that he has done and continues to do, such as he calls them yoga toes or his PAD 100, which help to like flex and point, and then how to walk most effectively, like we were designed to do by spreading your toes.
Yeah.
I mean, all of these things have led him to a point he's never had a procedure and he's competing at a world's level at 82 years old for his age group.
Incredible. Incredible.
I know. It's just amazing. So if you ever want an intro, but this is one of my favorite questions for you. I want you to share your best motivational speech for walking as medicine. So far, Dr. Anida Dua holds the record at 30,000 views and the most comments because people loved her analogies. So big shoes to fill there. But
Okay.
how do you
I know,
talk
and
to your
that's
patients?
that's a tough bar to reach, but I'll do my best. Yeah. So motivational speech for walking as medicine.
Yep, get me to walk.
Well, I think what I tell a lot of patients is that just getting started is winning the battle. I think a lot of people set a bar of, thinking they have to do a certain amount or, they failed. And just get up and start walking. And that in and of itself is a huge victory. The hardest part is the activation energy, to just get out of the chair and just start walking and be proud of yourself no matter how much you do on any given day. If you got up and you started, you should be very proud of yourself. That's a victory. Never feel bad that you didn't do enough. Never set a goal that, is going to be unachievable for you, but just get up and start, take that first step, and you're already there.
You got to start somewhere, and you cannot compare yourself to others. You can't compare yourself to Dr. Kevin Morgan. I mean, you have to start where you are. And one of the things that we talked about, he talks about actually in the first chapter of his book, is treating a diagnosis. It's important to treat the diagnosis as a loss, and you need to grieve the loss and go through the stages of grief before you can actually get the motivation to move forward
Yes.
and to start walking. And so I hear you're nodding, so I don't need to do that. But I think that that is really important for people to say, you know what, I can't do what I used to. I need to, okay, let's grieve that. I can't run a marathon. Okay, I get that. I can't run a marathon as fast as I used to. I can't even walk to the mailbox. Okay, we get that. But what can you do now? And what is your goal moving forward? And that's where
Yeah.
you gotta get in order to get that motivation, right?
Yeah, I think that the goal can't be, one that makes people feel it's unachievable. I think if you
Yep.
can get up and just start that activation energy, you should be so proud of yourself on any given day. Just get up and walk. Maybe after this interview, just get up and walk, do it. And you should feel so good about whatever you can do that day. Every day we progress a little bit. You're not gonna, set a bar that you're going to cure the disease in a day, but you just need a little bit further each day. Just get up and start, and you'll get there.
Okay, one deep one and then one quick fun one. Um, the deep one, because patients really love this. We want you to share a defining moment in your career, what we call these 6 minutes that matter. It could have been a conversation, a scene in a movie or a documentary you watched, a moment with a mentor, something maybe you observed, something that created an inflection point in your career or your philosophy when it comes to PAD. What was the defining moment for you that stands out?
Yeah, and this is really relevant, to stride. So, when I trained in medicine, I had amazing and have amazing mentors, and I worked in a world-class clinical trials group where we were studying drugs to reduce heart attack and stroke. And, mentors there, Dr. Brumwald, Dr. Sabatine, Dr. Morrow, and really learning about how to find novel therapies. But, at the same time, I had mentors in vascular medicine, Josh Beckman, Mark Krieger, where I remember seeing patients with them, and we didn't have any trial data. There weren't trials. There weren't, it's a very different thing. And we were in the room with patients, and you know, them talking with me, and it really struck me that we need to bring these worlds together and do better clinical research to learn novel approaches to improving care for PAD. It's not an unsolvable problem. It's been 25 years since we've had, an effective therapy since salostazole. That means that we need to do more research. And so to me, that was a moment in the clinic with a very different approach, which is, we're caring for each patient, but we don't have the trials to guide the care that said, aha, we've got to do better in our clinical research.
That was beautifully said. And I love that. And I love that during this interview, you've put out a call to patients to participate, participate, participate. If you guys are going to spend the time to do the research, then the patients should, take the responsibility of kind of coming in and being a part of the change that they want to see in PAD care. Okay, this is a fun one, and this isn't the patients actually asked for this one. So it's
Okay.
not to make fun of patients or anything else. We don't want to demean them. We don't want to make them more fearful of going to the doctor than they already are. But they want to know a moment with a patient that still has you kind of shaking your head, something that patients can learn from mistakes patients have made. It could even be, I cannot believe a PAD patient just said this or did that. In the most respectful manner. We did have one, and Dr. David Alper, who came on. He's on my board of directors, and he came on and he said, "Oh, I hate to say this because I had this sweetest little lady who was a diabetic, and she was having trouble keeping her socks up. And so she decided the rubber band wasn't quite working, they would still slip. And she was very proud of her decision to staple them
Oh
up
my gosh. Oh, geez.
until the
Wow.
point where, what do you think happened? Infection started looming. And so, bless her heart, yeah, don't staple your socks up. And I know diabetics, you end up with some of that numbness, right? Yeah, just because you can't feel it doesn't mean you're not doing
Right.
damage.
Right. Right.
So
Oh,
that was one
geez.
of those, but there are serious lessons to learn from.
Yeah, absolutely. I mean, this is sort of in the context. I think there's a lot of mistrust, in the sort of um, medical community. Some of that's earned, but I think a lot of people want natural solutions to the problems they have, and they worry about taking medications. And so, I have one patient in mind who, has high cholesterol, the diabetes is not well controlled, continues to smoke, and then, when we talk about treatments and treatments that they can access and pay for, thinking about, wanting to do it in a natural way and not taking the medical therapies. And, if I take a statin, my legs are going to hurt. And I'm thinking, well, your legs hurt because your blood vessels are blocked because your cholesterol is high. So, but I think it does speak to a broader, issue that we deal with and that's,
Yeah.
fear of the medical community and side effects and stuff. We have to do more education around it. But the medical therapies help. They don't hurt.
I think that that's a good point. I like your approach, and I'm glad that you took it with the context because I know that it was a tough question that I just had seen today. There was a big um, issue with a TikTok video of people in a gynecology office, and they were making fun of certain things that they saw or were left behind by women, and it created this fear. And that's with women who already go
Right.
and not fear going. And so that wasn't, I wanted to make sure that it's clear that that's not really the point of this, that patients just really want to know um what mistakes that they may be making and how to have a better conversation with their doctor, and what to believe and what not to believe. And so thank you for taking
Yeah.
in the direction you did. We really appreciate it, but thank you so much. Wow, you made it all the way through. Dr. Banaka.
Thanks so much for the opportunity. It's been a great conversation. I'd love to help or come back anytime. I really appreciate it.
Oh, don't worry. I can
Okay.
follow up with an email with many opportunities for you to choose from, because this has been one of the most insightful conversations I think that we've had in our 6 years. And we've had great conversations, but really talking to you and your demeanor, I mean, you are really an incredible, incredible human being, on top of being such a brilliant
Um,
researcher and surrounding yourself with a really great team. And so, just congratulations again. The biggest breakthrough in walking is therapy research. The STRIDE trial, led by Dr. Marc Bonaca, your entire team. Congratulations. And thank you from the bottom of my heart for all you do to help save life and limb.
well, thank you so much. It's a great honor. And thanks to all the listeners and thanks to the patients who trust me and our teams and our, you know, partner with us to try to make things better for people. So it's really, really, really an honor. Thank you.